a landscape that's more familiar to this group than most groups. So I won't set too much background, but about collaborating to ensure digital health equity. And I think that word collaboration has really been brought to life through the work that myself and my colleague Amanda Gambin have been doing with Sabine and a number of other people on this call, Mustafa Ali, Helen Chatwick, I just saw you there, over the summer, and doing it virtually. But the collaboration between the University of Toronto and Manchester University, it's been very fruitful and gives me great hope for establishing more equity in digital health. Let me tell you what I'll cover today, and then I'll tell you a bit about my background. So we'll talk about how digital equity and the digital determinants of health really flow through from this background of social inequities. So again, nothing that's a surprise to you, but I think by following that through, it helps us to identify important areas that need to be addressed in order to achieve health equity, and especially in digital environments. And how we can appraise digital health equity, how we can identify barriers and make really strategic changes to improve equity. And I'll be introducing the Health Equity Impact Assessment Tool, the HIA for short. And the HIA was not developed with digital health in mind, but we've adapted it and created a digital health supplement to really make sure that it's applicable to digital health. And that's what Sabine and the group have been helping to refine. So this will look familiar. Any of you who do clinical work will recognize this graph without my having to say too much about it, especially if I tell you that it really charts from February and March 2020. It doesn't go to the present, but really the uptick in virtual care. So in my work, so I'm a psychiatrist. I'm at the Center for Addiction and Mental Health, which is a large teaching hospital solely focused on mental health in Canada, and I'm at the University of Toronto. And I run our virtual care and outreach program, and I have run outreach for the last almost 15 years now to Northern Ontario, our province, and rural and underserved areas, and also to Nunavut, which is our most northern territory in Canada. And we try to go to communities. Relationship is very important, and I would love to give a whole talk on kind of the cultural safety of virtual care. But it really highlighted for me, in between times, people weren't getting the care that they needed. And so we've been really using a lot of, first of all, virtual care, but then increasingly other digital health tools over the last number of years to try to bridge that care and create more continuity of care. And also convincing our organization. There's a small, very steadfast group at our organization that is interested in digital health, and you will have met some of them. But the rest of our organization, wasn't necessarily convinced that this needed to be a cornerstone of healthcare or mental health care until about March 2020. And this is the initial graph of the very rapid increase in virtual care use. And it was because our program was already using it that was one lever to help scale that at our organization very quickly. And we now we're still doing well over 10,000 virtual care visits per month. But shortly into it, and maybe because we work in underserved contexts and are already aware of these things, don't worry, I know the fine print, it's a little blurred out, but you'll get the point very quickly, that there were real differences in how quickly people were able to access digital health based on a number of socio-demographic factors. So young people accessed it, first of all, more quickly, so you'll see a more steep rise, and it stayed that way. There has remained a divide in terms of age, gender, which is interesting. Women, females, identifying females were more quick to access virtual care. Those with different abilities, actually we did a fair bit of outreach at the beginning to try to adapt services so that was less marked. Ethnicity, I think this surprised everyone that our patients who were Black Canadian were much accessed virtual care much less. Those who were underhoused, that was not surprising because it was hard to access and find technology and spaces, and income. So we really saw it very early and right across the board. And that's actually what got me very interested in digital health equity. So what is that? We know that health equity is when people have, things are equitable when people have equal health outcomes, irrespective of differences in any socio-demographic group that you come from. So irrespective of race, language, socioeconomic status, etc. And we know that we have by no means achieved this in health in general. And one of the examples that I often think about, so I do a lot of work in Nunavut in the north. It's predominantly Indigenous, predominantly Inuit, and the rates of tuberculosis are 75 times higher than the rest of Canada. And it's been extremely difficult to eradicate, and yet we have the same medications. So it's a lot of social factors, in particular overcrowded housing is one, and a host of other issues. And that really highlights for me, that's an extreme health inequity, something very treatable that in a first world, for lack of a better phrase that comes to mind, country, we can still have such incredible inequities. And we know that those are very much shaped by the social determinants of health. So, and this is a list from the Public Health Agency of Canada. Again, not going to be surprising to anyone, but I always, when I look at this list, I always think, oh yeah, of course. Not everyone has the same access to health services. It helps me to think about all the different dimensions. And more recently, in Canada, we've added racism and oppression, and there's a real recognition that those experiences that people are immersed in from throughout their lives have a very real impact on health at all levels. So that can impact people's biology. It can impact their willingness and interest to access health care. It's a very important social determinant of health. So digital health equity, at least the way we've conceptualized it, is really an extension of that. So digital equity is achieved when people have equal outcomes through digital health, so they have equal access to digital health technologies and can achieve the same health outcomes as others, irrespective of socio-demographic status or positionality, social positionality. And that communities as well, so we don't just need technology, communities need to be adequately resourced to support this. We also need to consider things like people's cultural and community values and preferences and the ways that they access digital technologies. And I think that's also really important. Very quickly, our language around any kind of health equity can actually unwittingly and with all good intentions can contribute to health inequities. So we talk a lot about vulnerable populations, marginalized groups of people, and those things are true, but also to recognize people's strengths and the value and leadership that communities can bring to achieving equity. So myself and my colleague, Eva Surhall, we got quite interested in how this would map. Don't even try. This is, you know what, I'm going to go right to that. Not that it's complex, it's just a busy slide. What we tried to do was we took a very well-known model of thinking about how social determinants of health impact health at all levels and really map that onto what that looks like in a digital environment. And came up with kind of groupings that we called, instead of the social determinants of health, the digital determinants of health. So in order to have that equity, You have to have access. You need to know how to use, I'm looking at the third box along. You need to know how to use digital resources to achieve health and to seek health, or they can be used to avoid them, creating lots of problems. Digital health literacy, which I think lots of people are talking about now. Beliefs and values about virtual care. So a small example of that is, again, I work a lot with Indigenous communities, and obviously each community is very different and there are differences across communities, but we have encountered a lot of thought that if people use digital health, that health professionals will stop coming to their community. So there was a community attention in communities. Yes, you can get quicker access, but it's going to change the kind of healthcare that you receive, as one example. And also not being able to consult elders or have a fully integrated healthcare team. And then how well those digital resources are integrated into community and health infrastructure. And I think this is increasingly important, at least in Canada, and particularly I just spent some time in the US, and I think it's an even bigger challenge there. All kinds of shops popping up to offer like walk-in virtual care, but very unintegrated within the health system. And I think that creates its own kind of challenges. So these digital determinants really flow into that last column, what it looks like if you, actually, sorry, my screen is covered. I should know it all without looking at the diagram, but it really flows into what it means to have digital health equity. So again, that equal access, equal health outcomes, irrespective of your social positionality, and that we really commit to measuring and thinking explicitly about digital health equity, evaluating that, doing quality improvement. Okay, and this, there is an emerging literature for sure, and I know a number of you are writing about this. I thought I would highlight two papers to just show how this is being explored. So this, many of you will know Jay Shaw, also at the University of Toronto. So he and his team did a narrative review of health equity and virtual care. So we're now thinking broadly, but this was focused on virtual care. And these are the groups that they included in the review. They found 15 studies at that point. It was probably 2020 when they started it, but published in 21, really looking at a number of socio-demographic groups that might have some barriers to achieving digital health equity. And what they found was they looked at some of the challenges around digital health equity, or especially in virtual care, at multiple levels they found across these papers. So things that had to be attended to at the individual, challenges with the technology within the health system, and then social and structural challenges. And then across the papers, they pulled out what are some solutions at each of those levels. What are things that can be done? So at the community and patient level, so programs to enhance digital literacy, or we had, peer support who could help people get up to speed and get on technology. At the more sort of organizational or health system level, again, really measuring health equity, paying attention to it, promoting the achievement of digital health equity, providing training. I put down to support patients, but also training of professionals working in this area, all the way up to increased infrastructure and funding for digital health equity. So that's a great resource. And then this study it's a qualitative study by a group from Finland, and they actually used the framework that Eva and I put forward. And they did a number of focus groups with what they called key vulnerable groups, and really identified across each of those areas through speaking with people and doing the focus group. And then they organized, I'm going to show you, it's again too much to read, but just to give you an idea that in each of those areas across these groups, they identified the most salient equity barriers. So definitely worth a look. And I think those are amazing and very much needed efforts. But what we were interested in, and I'm going to spend the rest of the time on this, is those are great lists if you're already working with that specific group of people. But I think what's really important is the ongoing attention to digital health equity and the recognition that different groups, yes, there definitely is a checklist of things and tips. You should have access to technology. You should make sure that technology is accessible to people with different sensory, cognitive needs. Could rhyme off a whole list. But what I think is really important is engaging the communities that we're working with very early on in the development of health technologies, and understanding from them and with them what their barriers are to fully making use of those technologies. So we took this health equity impact assessment tool, and as I mentioned, adapted it. So what is the HIA? It's a decision support tool. It's not checklist oriented. It's a process, and it's used to identify potential unintended health impacts. So those could be positive or negative of any policy, program, initiative, and they've used the initial language of vulnerable or marginalized populations. So to really work with groups and think through so we have this great thing, we have this great device, and it's going to help you. It's an app, and it's going to help you sleep at night. But what are the unintended health impacts of that? And that might be some positive things that you gain from that app. Maybe it's got an alarm built in, and that helps you get up early for work. Or it could be unintended negative harms. Maybe now you don't let your children into your room because it's going to disrupt your sleep app. And that, sets off a whole other cascade. So really understanding and trying to surface at any point in the development or implementation of a health initiative, what might some of those impacts be. And I think I've touched on all these the why, the who, the when, the how. I'm going to show you the how. And another important point here is the when. So doing health equity impact assessments can happen at any point. It can happen ideally in the development of something, but sometimes we don't know, again, the unintended impacts. So it can happen halfway through. Things aren't going as you expected. No one's downloading the app. No one's using it, or only a certain group of people are using it. You can do a health equity impact assessment then, or something that's tried and true, but that you want to promote in a very different context or with a different group of people. You can do a HIA then. And this is essentially what I've just said. So it's often described as a living document or a living tool, something that's not really meant to end. It's supposed to be iterative, the process. Okay, and without further ado, I'm going to go through the HIA with you. And also really happy that I'm going to be in Manchester in a couple of weeks and hopefully get to work with some of you and go through this in more detail. So consider this a tasting, and anyone who wants to know more can certainly join us. Okay, so there are 5 steps to the HIA. I'm going to go through each one, but it starts with scoping out who are the people that you want to be using this, who are the people who are already using it, who are not using it, whatever the intervention is. So it could be an app, could be, we just worked with the digital, the pain mannequin, could be that, could be virtual care. Who do you want to be using it? Who is using it? What are some of the barriers that those groups face? And then, based on that understanding, what are potential impacts, intended, unintended, of that intervention? How do you want to try to mitigate those challenges or barriers? How are you going to monitor whether that works and whether it does improve health equity? And then thinking about disseminating that knowledge, both back to not just to an academic community, but to improve health equity elsewhere. So I'm going to go through each of those as we've applied. And this is the very old HIA template. It was developed in, I think it was the early, maybe 2010-ish first, developed then. And it essentially guides you through all of these different steps, which I'm going to do now. And we'll try to think about some examples as well in terms of digital health. So the scoping, actually, let me go back here and talk about scoping. So that's really one of the ways that the HIA has been criticized. And I've tried to draw attention to it already, but people don't just belong to one social category. And within groups, people are very different. So increasingly, we're still using the HIA, but we're thinking from an intersectional lens that people can be across these groups and can move between groups. And that, of course, we ourselves also come from multiple groups. So really trying to break down this idea that everyone gets a box. So we don't tend to list the communities the way that you see them here on the original HIA, and try to be, I would say it's like bringing critical reflexivity to doing the HIA. So when the scoping, it's really thinking who are you trying to target? Who is your end service user? What kinds of determinants of health are shaping that group, or might you see? So is a large proportion of the group living in poverty? Are they not well connected in terms of access to health services? Is it a different language group? So scoping that out first is the first step. And then looking at potential impacts. So using the data that's available to you. So, and you can see the full list here. I'm going to tell you about the process we use. The way that I like to do this the best is through focus groups when that's possible. So actually engaging with the people, the intended users of the health service or the app, whatever it is. And that's what we did with Sabine and Mustafa and Helen, is actually to meet with people. But really trying to, based on the evidence that's available, including talking to people, thinking through what are these unintended impacts, both positive and potentially negative. And here's a couple of examples. So based on housing, people may not have access to private space, so that may shape their use. And a potential positive impact might be if your app allows people to do something in more of a private sphere than they would be able to otherwise. On the other hand, it might be an unintended negative impact. So virtual care, we saw this a lot. People not having access to private space, then not wanting to have health care. So people in situations of domestic violence, for example, or overcrowded housing, may not be able to continue to see their healthcare providers. So thinking through those potential impacts, and I'm going to show you more examples in a moment, right through the HIA. We'll go through that. One thing that I have really found through the work with Sabine and Mustafa and Helen especially is how critical engagement and facilitation is. So Mustafa did an incredible amount of work to engage with the communities that were of interest and who we did the focus groups with. And I think engagement is just so critical. So if you get, not that this is bad, but this happens to us all the time. We have certain, we call them patient partners that we work with all the time. It's very easy to reach those people, and they come in willingly, they're super keen. Actually going out into communities and trying to connect with people that don't usually come in and give advice is so important. Thinking about diversity and who we're including. And also then, if you are doing it through focus groups, the facilitation. So here are some things, I wouldn't say it's random, but it's just a list that's developing. And we're going to be doing facilitation training and kind of problem solving through some of these challenges. But we also have at our organization a kind of new role of an equity coach, and that's extremely helpful. Like, so people who are very versed in this and can run, can go through the HIA and other. They don't just do HIAs, but that's an important role. And so again, I mentioned diversity and inclusion. More than one. Often when we first started doing this work, we have a patient partner. We need more than one. Even for them, there's a huge power differential. People come into this work with researchers and tech people and professors, and it's there's a huge power differential. So we usually make sure we recruit more than one person, and recognize that that person isn't meant to represent their entire group. Like, you don't work with somebody from a different culture and say, okay, you're representing that culture. So recognizing the homogeneity, and as I mentioned, intersectionality, and considering all through the whole process, how power and trust. So we have some groups that have been where there have been barriers based on history, colonialism. They don't tend to have huge trust in healthcare. So it's very important to be aware of that when you're inviting people in to the organizations. Remunerating people for their involvement, making sure that the involvement is accessible to them. Do they have to get into your institution? Are there barriers to them even participating? Stigma around language, which I mentioned already, and making sure to consider strengths when we're looking at health equity, not just the challenges and limitations. And this one, I bolded it and used anytime we use capital letters. Accountability for action. It's really, I find this work actually the process of it very fulfilling, very engaging, and it's easy to lose sight of the fact, like the why we are doing it. So we can get focus groups together and come up with all kinds of cool things, but really by doing it, we are committing to action, that's the purpose of the work at the end of the day. Okay. And then mitigation. Once potential impacts have been identified, what are steps you can take maybe to enhance the positive? Although I have to admit, we almost never end up focusing on the sort of positive unintended impacts. There's usually such a long list of the negative impacts, but and how do you address those negative impacts? And there's some simple suggestions here, but ideally those suggestions will come from the group. So access to privacy, just to pick one at random. So if that is an issue, how can you problem solve with people to create more private locations? You know, and one-on-one, that's another important thing. So we're talking about health equity. It happens at every level. So this can be, you know, I have a patient who really needs to be seen, doesn't have privacy. Can you go to your car? Can you talk outside? Can you go to a quiet space in the library? That kind of mitigation and problem solving is contributing to health equity as well. As then you go to your organization and say, listen, I've got this group of patients. That's awesome. We have virtual care. It's a pandemic, but not everyone's able to use it. And then working with the organization to say, oh, we need space. We still need space for people to come in person, even if it's to use digital technology on our property. So that's an example of a mitigation strategy. And now for some examples, and I'll wind it down so we have lots of time for conversation. So here, and of course, when you put it in a chart, it looks very nice. I'm going to show you the work from with the digital pain mannequin in a moment. That's more raw, but this is an example of a fully worked through at least at one point in time. So we were focusing on our neurodiverse group at the hospital I work at, and a group they like to be referred to as autistic people, and did some focus groups and really looked at some. So you'll see on the left, I'm going to go left to right, and unique cognitive profile. And that for not every person in the group, but for many people in the group, included actually very high digital literacy and really being drawn to using anything digital, and some more challenges around social connectedness. So unintended positive impacts were, wow, it was really easy to get most of this group, or many in this group, to use digital technologies. There was a high degree of comfort. And there's actually a preference within most people in the group to receive care at home and virtually. And we've had challenges getting people back into the settings, the healthcare settings. And those led to some unintended negative impacts. So the materials that we were using, for some people were not plain language enough, were not engaging in the right kinds of ways. And the big thing was missed opportunities for social interaction, which was having an unintended negative impact on their health and well-being. It's also led to some research questions. So we always have like a more information needed or a parking lot, like what else do we need to look at? There's usually more than enough to work with in terms of what is identified. And so some of the mitigation strategies that we collaboratively came up with, we're using that interest in technology, providing peer support for digital literacy. So if there were people across that group that didn't have that, then some of the people who were very high in digital literacy, we've engaged to help those that weren't. So that was a way of using their interest in technology and their skill and furthering their social connectedness and also helping others within that group. And it provided employment opportunities and involving people from the group, so people with lived experience of autism, to look at our materials. We identified 2 ways of monitoring or evaluating this. So measuring digital literacy, we looked into a number of tools to measure that. And then really at the service level, tracking service utilization data. And you can see some of the dissemination strategies we used. Reporting back to the group, so not just getting information from the group, but reporting back to them, making that information available is really important. And the other thing I'll say is that the monitoring piece, you don't have to do the HIA with, it's nice to get to every column with the group, but you can also engage the group, including people with living experience, and then bring it back and say, okay, how are we going to monitor this? What are we going to do and how are we going to monitor this? And I know with the pain mannequin, that's definitely what we found. There was so much discussion around impacts and mitigation, and the monitoring was less meaningful to some people than to others. And this is just an example from that pain mannequin work from our focus group. Literally just took a screenshot, and what we did, and actually now we want to do this all the time. We had to do it because we were working in a virtual environment. We used a whiteboard Miro, and the facilitator put in the notes as we were talking. So you can see the different columns, and then we were able to pull over. There's very little on this example under the negative impacts because they've all been moved over to the mitigation, but so we're able to move these around. And the nice thing about this is that the focus group, the people involved, were able to see that we were literally taking down their words, we were moving it over to mitigation, and then with the group, we really looked at what do we want to focus on to improve equity. So it was a very fluid, I'm saying fluid, sometimes it felt chaotic, but it was people had lots to say. All right, and I've already mentioned about monitoring. I wanted to mention one last thing. I think there's all kinds of work coming out in terms of measuring the experience that people have engaging with digital health. This is specific to virtual care, but we developed a tool. This was before the pandemic, a client experience survey that actually I'll go one slide ahead, that looked at quality of care, patient experience based on domains of quality of care. But what we added to it, in light of everything I've been talking about, is trying to track and understand people's experience of the quality of virtual care based on health equity. And so we added a whole list of sociodemographics to that. So that's one way. So you can use or develop questionnaires, but then to make sure that you collect information on sociodemographics so that you can monitor quality of care and outcomes by some of the social equity things that you're concerned about. And then dissemination. I won't say too much, but this was so from that virtual client experience survey. So we found across our organization that overall people were very satisfied with virtual care, but we did identify some equity related issues that we're still dealing with. So across different groups, it was not equal satisfied people were with virtual care. But there are all kinds of ways to measure outcomes, which we could probably have a whole other hour on. And I've left some resources here. The general HIA tool, we'll be getting the digital health supplement to the HIA tool online, and I'll definitely be bringing lots of copies with me. And my contact information is there. But you can reach me for sure through Sabine or through Charlie, and some citations.
Thank you very much, Allison. That was wonderful.